Well, good afternoon, everybody. How's everybody doing? Can folks hear me okay? Yeah, is this? Oh. As you can see from this title, juvenile onset bipolar disorder, we're going to talk today about what we know and what we don't. And I think it's really important because the field of clinical psychology and psychiatry is changing and evolving. It's always changing and evolving. And it usually changes and evolves like other sciences, other disciplines, largely based upon research, right? Research. Research helps inform us in terms of our understanding of something and also our handling or treatment of something. And that's the area or the topic of juvenile onset bipolar disorder is no exception. I'm going to start out this discussion today really by talking about two cases. And what I'd like you to think about in terms of these two cases is keep in mind some of the symptoms, because we're going to come back to these two cases at the end of our discussion today. Okay? So let's take the first case here. We have 8-year-old Johnny. Okay? Johnny was referred to a mental health professional because Johnny has frequent and aggressive temper tantrums, very violent temper tantrums. These temper tantrums happen sometimes randomly, but sometimes reactively to when he either wants something or doesn't get what he wants. Okay? Johnny is also described as very moody. Okay? He's also described as very oppositional and defiant. Okay? He's not compliant either with many adult requests, those adult requests being parents or even teachers. Johnny's also described as being inattentive and distractible and hyperactive. 15-year-old Marissa. Marissa is also described or categorized, who was also referred for mental health treatment, counseling, potentially psychiatric treatment, because she's described as being moody. She has bouts of depression, and some would characterize that depression as serious, significant, sadness. She has a history of stealing, also has a history of having been sexually abused, and she also has been engaging in regular substance use for about 6 months to the last 9 months. Okay? So remember, with Johnny and Marissa, I just want you to think about these symptoms, think about these characteristics, because we're going to come back to them later. Taxonomy. I don't know if you're familiar with that term. It's a term used in science to describe a classification system. Okay? So, in the area of clinical psychology or psychiatry, okay, I'm going to use those terms interchangeably today. When we think about clinical psychology, we think about usually folks with PhDs in clinical psychology, okay, who treat mental health conditions or mental health problems, but who usually can't prescribe medications. So they treat folks non-pharmacologically. When we think of psychiatry, we think of MDs, and we typically think of them as folks who treat patients, whether they be kids or adults, with medications or use psychopharmacology. Okay? That's changing a little bit. There are some actually clinical psychologists in some states who do have limited prescription privileges now. Okay? So this is part of the field in the field of clinical psychology and psychiatry changing and evolving. Okay? So that's sort of the distinction between the two. So from an old taxonomy or nomenclature perspective, have folks heard of the DSM, Diagnostic and Statistical Manuals? Yeah, they just came out with the 5 recently, right, exactly. Prior to the 5, there was the 4 and the 4 with revisions, and there was the 3 and the 3 with revisions, and the 2 and the 1. With some of the older versions of the DSM, not the 5, okay, prior to the 5, prior to the 4R, we used to think of, when we thought of Marissa's and Johnny's symptoms, sometimes, depending on who the practitioner is or was, Marissa or Johnny may get diagnosed with any one of these things: ADHD, attention deficit hyperactivity disorder; ODD, or oppositional defiant disorder; conduct disorder; some combination of those two. Many kids who get diagnosed with ADHD may also get diagnosed with ODD or conduct disorder, so sometimes they co-occur. PTSD, or post-traumatic stress disorder; depression, and maybe some others. So when we think of Marissa's symptoms, we think of Johnny's symptoms. Historically, with our old systems of diagnosing, they may have got diagnosed with any of these. With more recent versions of the DSM, not the DSM-5, but more recent versions of the DSM, we would also include this category of bipolar disorder. So maybe, depending on who the practitioner was, Marissa or Johnny may have been diagnosed with a bipolar disorder. Let's talk a little bit about what bipolar disorder is in general, at least from the perspective, at least from an adult perspective. Okay? Because I think it's really important, and we'll come back to that, because really, the jury is still out as to really what bipolar disorder is in kids. And again, this will be clearer, I hope, as we go through this talk today. When we think of bipolar disorder from an adult perspective, meaning adults who get diagnosed with bipolar disorder, we typically think of this: discrete periods of debilitating depression and discrete periods of manic behavior. When we talk about depression here, we're talking about real severe depression. We're not talking about run-of-the-mill sadness, because sadness affects whom? All of us, right? It affects every one of us. Depression, on the other hand, okay, may not affect all of us, but it can affect a large percentage of us. We typically think of depression here as clinical depression, real serious depression. Real serious depression that lasts for a long enough period of time, and it interferes significantly with someone's functioning. Okay? Those are some of the classic things we tend to look at when we think about depression. So one part of this bipolar disorder is depression. The other part is manic behavior, or mania. Mania is typically behavior, that really falls out of the realm of normal. Excessive lack of folks who can function for long periods of time without sleep, folks who go on spending sprees, who spend tons of money, okay? People who think they're omnipotent, who believe that nothing can go wrong, or they're immune from anything bad happening to them. Okay? Some of these folks can be delusional as part of their mania, who are not really in touch with reality. Okay? So it's behavior like that, real serious behavior like that. Okay? Now, other than the fact that there's two aspects to this problem, mania and depression, the other key element, and it's really key here, is discrete periods. Okay? And what do I mean by that? What I mean by that is, in order for someone to have a bipolar disorder, and there are different kinds of bipolar disorders, the depression has to occur during a discrete period, and then the mania has to occur at another discrete period. Okay? So it's not like someone's depressed 1 minute and manic the next minute. Okay? Sometimes that's confusing. Okay? Because sometimes it'll sort of, the lay interpretation or what you might see on TV or some place in the media, right, is that someone's up and down like this. That's not bipolar disorder. It's discrete periods of depression and then discrete periods of mania. Okay? Is that clear? I think it's really, really important. Okay? Really, really important. Is that different than what folks might have thought prior to today? Okay. Okay. Now that's even the case for something called rapid cycling bipolar disorder. There's a version of bipolar disorder. Again, we're talking about adults here, but there's a version where the periods happen more frequently over the course of a year. Okay? But even with that version, the periods are discrete. And they have to be discrete in order for that diagnosis to be appropriate. Okay? So again, with bipolar disorder, when we think about it from an adult perspective, we think of depression, we think of mania, okay, and we think of discrete periods where each of those happen, even when it happens more frequently, like in the rapid cycling type. Do folks know how bipolar disorder is diagnosed? Typically, you think of it being diagnosed by a licensed mental health professional, whether that licensed mental health professional be a psychiatrist or a non-psychiatrist, but typically we think about it as from a licensed mental health professional. Are there medical tests that are used to diagnose bipolar disorder? Again, we're talking about adults here. Are there medical tests? So can we point to a medical test, some sort of litmus test, that we give somebody and that comes back with objective information as to whether or not someone has bipolar disorder or not?
I think it's more a checklist, isn't
it? It is. It's a clinical diagnosis. There are, at this point in time, in terms of where the field is, in terms of the technology we have available to us, okay, the resources we have available to us, there is not a test or a combination of tests that we can use medically to say whether or not someone has bipolar disorder or not. Therefore, it's reliant on the mental health professional to know what bipolar disorder is, to understand what the diagnostic criteria are for bipolar disorder, okay, and to use that appropriately, hence a clinical diagnosis. I've been around for a while as a practitioner, as a supervisor of other practitioners, as an academic, etc. And I can't tell you how frequently and unfortunately folks used, okay, not just for bipolar disorder, but other disorders as well, use criteria incorrectly, don't pay as close attention to it as necessary, and hence may label someone something that they actually don't meet criteria for. Some of the other implications include treatment implications, right? Potentially getting medications that are not indicated, potentially getting, non-pharmacological interventions that aren't indicated either. Okay? So it's real important that mental health professionals understand what the problem is here, bipolar disorder, and knowing the diagnostic criteria. The DSM puts forth diagnostic criteria for everything that's in that book. Has anybody here seen that book? The latest version? Yep. It's pretty thick, right? There's a lot in there. There are diagnostic criteria for every diagnostic entity like bipolar disorder. It's not just a list of the symptoms, which are important. It's a list of the other criteria. For instance, how long do the symptoms have to go on for? Right? How much do those symptoms interfere with someone's life? Do those symptoms occur, do they need to occur just in one setting, or do they have to occur across settings, especially when we talk about kids? Okay? So there are a lot of things that are looked at, that are put forth in terms of diagnostic criteria, that has been my experience, and it's been an unfortunate experience, that not all mental health professionals look at as closely as they should. We started identifying very difficult and challenging kids probably about 20 years ago, labeling them as having bipolar disorder. Many of the symptoms that I described with Marissa, many of the symptoms I would describe with Johnny at the front end, okay, may have led, depending on the practitioner, may have led to a diagnosis of a bipolar disorder for each of them, for both of them. Okay. The results of that practice over the past 20 years has led really to children and teenagers being diagnosed with bipolar disorder 40 times more frequently than they were prior to the past 20 years. 40 times. It's a lot. Right? It's a lot. Does that mean, for instance, that the prevalence rate has changed that dramatically? Does that mean now we're better at identifying these kids, therefore we're seeing an increase and these numbers are accurate? Or does it mean other? It's stunning. The number's stunning. 40 times. It's interesting because when we talk about kids, yeah, at one point in time, we didn't think kids had depression because they may not have manifested depression in the same ways as adults. At one point in time, we thought aggressive kids were then what? Depressed. And they were just masking their depression with aggression. So we have all kinds of conceptualizations about kids' problems and disorders. Usually those conceptualizations and perspectives, they come from an adult perspective. They come from our understanding of adults, and that implies what? Yeah.
Kids are the same as adults.
Well, kids are the same, or junior adults, right? Kids are junior adults. And what we know differently now from the study of developmental psychopathology. Okay, it's a very specialized discipline in clinical psychology, developmental psychopathology. We know differently now that kids are not always junior adults. Okay? There's not necessarily a linear progression from kids to adults in terms of some of these things. Okay? Which really complicates it, doesn't it? Really complicates things in terms of our understanding. So the problems with this increase, okay, this 40-time increase in the use of the bipolar disorder label in kids really is about largely trying to what? Trying to cram a square peg into a round hole. And that goes back to what we were just talking about, right? Trying to use an adult perspective to understand kids' problems, okay? Which may work sometimes, but doesn't always work. Okay? Doesn't always work. Those practices, the practices of what? Of diagnosing bipolar disorder in kids, weren't necessarily borne out by research. Okay? Folks started using the label with kids and using the label a lot with kids, but it wasn't necessarily supported by research. Research wasn't saying, oh yeah, by the way, our findings are showing what? That kids who display these problems, like Marissa and Johnny, have bipolar disorder. Okay? Research was saying something different. It was saying, we don't know yet. And why don't we know yet? We understand pretty well what adult bipolar disorder is. we were using that adult language to understand kids who were displaying symptoms we didn't understand very well. Okay. How would we know? How would we find out, okay, whether those kids then look like the adults with bipolar disorder? In order to really understand whether or not kids, if we label them as having bipolar disorder, again, with adult language and adult perspective, in order to see whether or not those same kids are going to look like the folks we understand to have bipolar disorder, right? We have to follow them over time, right? We have to follow those kids over time to see what they eventually then look like. That's one sort of research practice that's been used over the past 20 some odd years now for us to better understand juvenile onset bipolar disorder. And we'll come back to that in a second. The other problem, or potential problem, with the 40 times increase in the use of bipolar disorder among kids, that diagnosis, is its treatment implications, especially what that means in terms of the use of some really heavy-duty psychopharmacological agents. Okay? Typically, with adults who get diagnosed with bipolar disorder, they get diagnosed with bipolar disorder, they are put on a mood stabilizer. Okay? It's a pharmacological agent that helps regulate mood. Okay? One of the more serious mood stabilizers that's used in the treatment of bipolar disorder is something called lithium. Are folks ever heard of that before? Lithium is a heavy-duty, very heavy-duty mood stabilizer that actually has evidence to support its use with adults with bipolar disorder. Okay? It's been shown to be effective. However, there are potentially some real bad side effects associated with the use of lithium, including some potentially deadly side effects associated with lithium, especially if the lithium is not managed properly by an MD. Okay? Now, with the practice of diagnosing bipolar disorder among kids, we ventured into this. And that is the use of some heavy-duty mood stabilizers among kids, okay, including lithium. One of the problems, in addition to all the ones that I know you're thinking about now, okay, and there are many, but one of the problems is we don't know what effects chronic lithium use has on not only the developing brain, but also on kidney functioning. Okay? Because lithium, when someone's put on lithium, their kidneys have to be monitored really closely for its functioning. So we don't know what the effects are over time. Okay? We're thinking they're not very good, but we don't know. So all these things and others have been really problematic in terms of its association with the increase in the use of bipolar disorder among kids and teenagers. For the past 20 years or so, with this increase in the use of bipolar disorder among kids, researchers have started to roll up their sleeves. Okay? A lot of research supported by the National Institute of Health and Mental Health, okay, around looking at more closely what is juvenile onset bipolar disorder. Okay? Is it what we think of when we think of adult bipolar disorder? Is it something else? Okay? And that really is based upon practitioners seeing these kids and thinking that maybe these kids really are not the same as adults, and looking at research findings. And one of the important research findings that has come over the past 20 years is that many of the kids we labeled as bipolar disorder, like Marissa and Johnny, remember Marissa and Johnny? Okay. Many of those kids, when we follow them over time, okay, they don't always look like adults who have bipolar disorder. In fact, many kids who get labeled as having bipolar disorder in childhood or the teenage years, as adults, don't meet diagnostic criteria for bipolar disorder, and instead, more often, meet diagnostic criteria for just depression. And I don't mean just depression, but depression, just depression in relationship to depression and mania. So depression and for anxiety problems. Treatment, even pharmacological treatment in adulthood for depression and anxiety problems is much different than the pharmacological or medication treatment for bipolar disorder in adulthood. We don't use mood stabilizers with adult depression. We don't use mood stabilizers with anxiety disorders. These research findings that we just talked about, right? And some of the anecdotal stuff, the information that's coming from practitioners who treat either medication-wise or non-medication-wise the kids we're talking about, our kids in question, really has led to a new classification in the DSM-5. DSM-5 is the latest diagnostic and statistical manual, just came out last summer. Okay? It hasn't been fully implemented yet. It's in process of being implemented, meaning what? Meaning that there's a grace period usually when a DSM comes out, a grace period that practitioners have to really understand it, to be able to use it, okay? But one of the strongest changes in the DSM across both child conditions and adult conditions has been this new diagnosis, or this new category, I should say, and that is this one, disruptive mood dysregulation disorder, or DMDD. Our field loves acronyms, loves acronyms, okay? And this is no exception, okay? Disruptive mood dysregulation disorder. Let me come back to this older one in a second. What is DMDD, or disruptive mood dysregulation disorder? Okay. Here's some of the diagnostic criteria. Okay. First of all, in terms of age, which is important here, shouldn't be used before the age of 6, but should be used before the age of 10, and never after the age of 18. Okay? Typically, with a lot of childhood categories, psychiatric categories, there's an age criterion, and this is no exception. So, before the age of 6 is a no-no, between the ages of 6 and 10 is yes, never after the age of 18. Here we're talking about kids, okay? Onset again between the ages of 6 and 10, right, typically, who are what? Moody and irritable, frequent temper tantrums, maybe depressed, maybe anxious, disruptive. All those problems are serious enough, and they have to occur across setting. For kids, across setting means home and usually school. Okay, so all those problems, home and school, okay, they have to have a duration of at least 12 months, so 1 year. And for a child that age, that's a long time, right? That's a long time, okay? And during that time, there can't be more than 3 months where there's no symptoms at all, okay? No symptoms at all. In terms of getting this diagnosis of DMDD, it can't occur before the 6th. That doesn't mean that someone isn't at risk for that. However, that said, you could diagnose someone, okay, with a bipolar disorder younger than 6. We're getting the paradox here, right? Yeah, absolutely, you could, and folks still do. okay? Just because we have this new diagnostic category, DMDD, that doesn't mean bipolar disorder isn't still used among kids. It is, okay? It's hopefully going to be used, and this is an empirical question, right? It's hopefully going to be used less frequently, okay? We don't know yet, just came out. And we think this category or this classification better accounts for some of the challenges kids have and potentially mitigates against what? This potential liberal use of bipolar disorder among kids. So DMDD, okay, is and isn't supposed to be used to replace bipolar disorder among adults. Hopefully that's clear enough, right? It's a little confusing. We're hopeful, the field is hopeful, for those of us who take a more conservative approach to the use of labels with kids in general, okay, across the board, not just with bipolar disorder, we're hopeful that this category at least will slow down on the diagnosis of bipolar disorder among kids. And moreover, and probably more importantly, will then limit the amount of times or how frequently heavy mood stabilizers are used in the treatment of kids. Okay. Now we're talking about treatment, right? We're talking about treatment from the perspective of, well, if you have bipolar disorder or you have something like this, medication is the only thing that can be effective. Well, that's not necessarily true. There are non-pharmacological interventions that don't necessarily cure the problem, but can really help folks who have to deal with kids like this, like parents and educators, help them manage the problem better. So, I'm going to come back for a second. We talked about Johnny and Marissa at the front end, right, at the outset. Remember those characteristics, or at least some of those characteristics? Given what you now know, what would you say about Johnny and Marissa? For instance, bipolar disorder, an appropriate classification for one or both. DMDD, other. Marissa's got symptoms of a lot of different things all over the place. In order to really figure out what that really is, a really skilled diagnostician would have to really be able to understand her history, when these things happened to her. Like, for instance, we said at the outset, if I can go back here, she had a history of sexual abuse, when that happened. So it's really complex. And it typically is, even for easier kinds of things, especially if a practitioner really takes it as seriously as they should in terms of understanding things. Yeah. Even aside from medication treatment, even non-medication treatment, we really need to understand better what the problem is, because we know now there's a whole lot of research that's been done looking at the effectiveness of non-medication or kinds of therapies and how effective they are with different kinds of problems. And there are some that actually have been shown to be highly effective with specific problems. So it's incumbent on us as mental health professionals to really go about doing the hard work, rolling up our sleeves, trying to figure out as best we can what the problem is really about. And that really has then implications for what we do to treat, whether it's medication or non-medication. And again, I keep on saying especially with kids. I say that because, let's face it, they're more vulnerable. I spent much of my early career in medical schools teaching psychiatrists how to understand psychopathology, etc. And they don't necessarily come to the table, and this is maybe a kind of an editorial here, but they don't necessarily come to the table understanding non-medical reasons for things. Like, for instance, we know from the developmental literature, okay, not even the developmental psychopathology literature, that the kind of structure and supports kids get in general plays a large role, okay? Type of parenting styles plays a large role as to their behavior. The thing I would hope that came to light today was that kids are not junior adults, number one, right? They're not junior adults. This whole issue of bipolar disorder is likely very different with kids and adults. Okay? The jury's still out. Okay, the jury's still out, but we're getting closer, I think, to understanding it better and understanding that it's different. Okay, that the whole issue of diagnosis and the diagnostic process is should be complicated, should be taken seriously, and folks should really adhere to what they need to adhere to consistently.
Let's thank Dr.
Thank you.